A common pitfall that GP trainees make is not taking a targeted history. In this video, I'm going to show you how to take a targeted history. If you're watching this video, chances are you're preparing for the MRCGP SE exam. So we're going to go through a case example of an urgent and unscheduled care. If you're new here, hi, my name is Dr. Erwin Kwun. Over the last couple of years, I've been helping GP trainees to get through the MRCGP exam. Let's dive right into the video. Let's say you've got a 43-year-old female who's presenting with epigastric pain. How are you going to approach this case? When you're thinking about this case, make sure that you look at the demographic. Think about any risk factors in the case information. Think about what could it be? What are the common differentials? So it could be patient presenting with gallstone, it could be dyspepsia, or it could be a patient who's coming with pancreatitis, which is more occasional, or it could even be myocardial infarction. When you're taking a history, it's very important in the beginning, in the golden 1 minute, to ask open question and let the simulator tell you the story. The simulator has got an opening statement and they've got a story that they might tell you. So for example, simulator might tell you, I've been having this pain for the last few days now. Yesterday was really bad. I couldn't sleep last night. This pain is getting worse, doctor. The story that the patient is telling you is helpful because you can pick up on the cues here about what they're telling you. They've been having this for the last few days and the pain has worsened. Encourage the patient to tell you more about the narrative. So you might ask more about the story. So tell me, how did this start? So when you ask this open question, the patient will tell you a bit more information. And what you want to do is actively listen to what the patient is telling you. Once you've got the story out there, the next thing that's really important to get early on is a patient's health agenda. So this is idea, concern, expectation. There are many ways of asking ideas, concern, expectation. However, it's very important that you ask the ideas, concern, expectation in context. A good way to ask a patient's idea is to ask the patient, did you have any thoughts about what it could be? Then the patient might tell you, oh, I've been thinking whether this could be the takeout I had a week ago. So then you've got the patient's idea. If you want to ask a patient's concern, you might say, was there anything you were worried about? Then the patient might tell you the concern. Let's say the patient tells you that this pain's been worsening. This is a good time for you to show empathy. You can say to the patient, I hear you, I understand that this pain's been quite bad, and I'm glad that you got in touch today. The next thing you might want to ask the patient is the expectation. It's best if you don't use the word expectation when you're asking for the expectation. So you might ask the patient, what were you hoping I might do today? So then the patient will tell you the expectation. So now you've got the first bucket, which is the ideas, concern, expectation bucket. The next bucket that you want to fill is biomedical history. Most doctors are very good at eliciting the biomedical history, and sometimes they overdo that part. Due to the time constraint within the SEA, it's important that you don't ask various questions that's not going to progress your consultation. Be selective of the question that you ask in your data gathering. So if you're going to ask questions in the biomedical history, then make sure that you're asking pertinent questions that's going to help you to find out what's the problem with this abdominal pain. So then you might think, what question should I ask this patient? It's important that you inquire about the site of the pain. When you know the site of the pain, it's going to be easier for you to come up with differential diagnosis. So, for example, if a patient tells you that they've been having pain in the right side of the tummy, then you might be thinking whether it could be appendicitis, it could be gallstone. So it's important that you ask a question that allows you to identify the site of the pain. So I might say to the patient, could you tell me where did this pain start in relation to your belly button? Then they might tell me, oh, the pain is above my belly button. Then if they're telling you that it's above or if it's in the center, then you will know, and based on the location, you can think what could be the differential diagnosis. Other thing that you want to ask is the onset. Did this pain start suddenly or gradually? What's the characteristic of the pain? Is it a burning pain? Is it a sharp pain? Or is it a dull ache? You might want to ask the triggers. What are the other associated symptoms? For example, if the patient is having any vomiting, any shivers, or any fever, that will help you to understand what type of pain that they've been having. And then think about anything that makes it better, anything that makes it worse, whether the pain's been radiating somewhere else. So you might say to the patient, has this pain been moving anywhere else? That's helpful to understand the nature of the pain and whether it's spreading anywhere. So if it's a woman of childbearing age, make sure that you don't forget about pregnancy. Ask about their last menstrual period and consider whether they could be pregnant. It could change the list of differential that you've got. It's vital that you think laterally. If a patient is presenting with epigastric pain, it's important that you make a safe assessment. Think about the possibility of a myocardial infarction. Consider asking about any chest pain, shortness of breath, or any clamminess, or any pain down the arm or up the neck. Consider what the patient has been taking as well. So if a patient has been taking ibuprofen for the last few weeks, then it could put them at risk of gastritis or even duodenal ulcer. So make sure that you're considering the risk factors in the history. If a patient's been smoking or drinking alcohol, they could be at risk of various other problems as well. So let's say the patient has been drinking heavily, then you might be thinking whether this epigastric pain could be due to pancreatitis, for example. So once you've taken the biomedical history, you've got the second bucket filled. Then the next bucket is the psychosocial occupation and situation. So in this bucket, what you want to know is whether the patients had any problems from this abdomen pain that's affected their life. So you could ask the patient, how has this abdominal pain affected you? Has it stopped you from doing anything? Have you had any recent travel? Other things you want to inquire would be whether they had to take time off work due to this pain, or whether there's been other people in the household who've had similar symptoms. For example, if a few people in the household have got abdominal pain, diarrhea, and vomiting, then you might be thinking whether this could be gastroenteritis, for example. So once you've got the ideas, concern, expectation, the biomedical history, and the psychosocial situation and occupation, then you're good to go to move into the clinical management. So remember the patient's ideas, concern, expectation, and readdress them. For example, if the patient's been worried about this pain, not been eating, and thought it could be due to the takeout, and you think this is possibly due to pancreatitis, then you can use a pivotal phrase to readdress the patient's ideas, concern, and tell them what you're thinking. So you might say to this patient, I appreciate that you've been thinking this could be related to what you've eaten, and you're quite concerned about this pain. Having listened to you today, I don't think this is related to the food that you've eaten. Yesterday, you've been drinking quite a lot, and seems to me that this pain has been triggered since you had a drink last night. I think what you've got is called pancreatitis, which is a problem with an organ in the abdomen, which is related to producing hormones such as insulin. Have you heard of pancreatitis? So then, if the patient hasn't heard about it, then you can explain a bit more about what pancreatitis is, and explain how you're going to manage this. So by doing that explanation, then you're going to show the patient that you've listened to them, and you understand where they're coming from, and you've explained to them what you think this is. Then you can explain what's your management. So let's say if it's pancreatitis, then this is where you might consider an admission. So the patient might not be expecting an admission, and it's important that you have this decision with the patient together, and you have discussion so that you come to a shared decision. You might say to the patient, when we suspect pancreatitis, this is something we need to take seriously, and I'd like to tell you a little bit more about how we can manage this, if that's okay with you. Yeah. So normally for pancreatitis, it's one of those conditions we need to arrange urgent blood tests, and it's best if we can arrange for you to be seen in the surgical assessment unit. So this is something we'll do in the hospital. What are your thoughts if I had to arrange for you to be seen today and have some urgent blood tests and further assessment by the surgeon today? I'm telling the patient my thought process, and I'm involving the patient in the decision making. And the patient might be thinking, and she might say to you, well, I was not expecting to be admitted to hospital today. I've got some plans this evening. Then your job is to consider what alternative or how you can persuade the patient to come to a decision that's going to be best for her. So you might say, well, I appreciate that you've already made some plans today. However, this is quite serious. You've mentioned that this pain's been getting worse and you've been quite worried. So it is important that we rule out what it could be. And if it is pancreatitis, it's very important that we get you seen and treated. So would there be any possibility that you could change your plan if I arrange for you to be seen today? So then the patient might be thinking, and then depending on the simulator script that they've got, if you're managing to persuade the patient and showing sensitivity, the patient might choose to go along with your plan, and you can explain how you're going to arrange the admission, and make sure that you inquire how will the patient get to the hospital safely. Patient is presenting with this type of pain, then it might not be safe for that patient to drive. So you need to consider how to arrange for this patient to get to the hospital safely. Then you might need to arrange a follow-up appointment to tackle the other problem in the history. For example, the patient's been smoking or drinking heavily. This is something that you might want to address at a later date. So in terms of safety netting, it's also important to let the patient know what are the signs or symptoms to look out for. If there's any worsening of the problem, then to stop the call and dial 999. So by having a plan that's robust and showing that you're managing the patient, not just having a generic admission, but involving the patient in the discussion, then you're going to score higher. If the patient refuses to have an admission and they definitely don't want to be admitted, then it's important that you discuss what is the alternative that you might arrange. Also explain to them the consequence, and there is risk involved in that decision. So it's also important to let them know that there is a risk if they are not being seen and treated for this problem, and it could be potentially life-threatening. So by having that discussion with your patient, this is where you're having shared decision making. A lot of GP trainees think that shared decision making is just sharing options, but it's not just sharing options. It's where you're having that discussion with your patient and involving them and making the decision together, as opposed to just sending the patient to hospital, which is a doctor-centered type of decision making and management plan. So be aware about being doctor-led or patient-led, and try for a balance where you're showing that you're considering the patient's circumstances and preferences and managing the patient and providing person-centered care. If you find this video useful, you might want to watch the next video in which I show you how to break bad news remotely. Click here to watch it. Take care, everybody. Bye-bye.